this month's nursing teaching program. So this month we are going to talk about introduction to pediatric hematopoietic stem cell transplant. And Dr. Chintan and his team has graciously agreed for doing this. So, without much ado, I'll introduce Dr. Chintan Vyas. He is clinical lead pediatric BMT and the Children's Hospital, Mumbai. So he and his team will be taking forward this lecture, and I'll hand over to you, Dr. Chintan.
Yeah, thank you very much. Am I audible?
Yeah, you are.
And is my screen visible?
Yes, it is.
It's moving, no?
Request the audience to put the questions in the chat boxes so that we can discuss it after the lecture.
So my screen is moving, correct?
Yes, it is.
Yeah. Okay. So in the first 15 minutes or odd, I would like to give you a brief outline of the basics of BMT. And then my nurse manager, who is a pediatric BMT nurse manager, will tell you about the importance of the nursing learning for this topic. So as you are all aware, that the transplant we are doing for the last 6 to 7 decades, and the starting of transplant has happened from the invention of radiation. The first after nuclear world war, because of the radiation, we understood the role of radiation in the killing in the cancer cells treatment, and subsequently the immunosuppressions and all have been invented, like cyclosporin and ATG. Now, in this era, in 1970, is the first transplant for bone marrow transplant for a pediatric patient, a child for Viscott Aldrich's kid was done in 1970s, and from there we evolved that what is the role of immunosuppression in the transplant, and also we established the unrelated donor bank, and then subsequently we found out that how we can improvise the overall outcome of transplant by doing the better pre-transplant planning, actual transplant conditioning, and post-transplant care. So as you are well aware that the transplant is mainly divided into two type of transplant in hematopoietic transplant. One is autologous, which is your own cells, and the second is allogenic, and the cells which we can take it from sibling or from the unrelated donor or from the relatives. And the third source is a cord blood source. So we'll explain you about all this thing. Now, as you can see, this is a patient and this is a donor and patient. So if you are using the patient's own cell, it is called autologous transplant. And if you are using the donor cells, it is called allogenic transplant. As you can see, that various type of donors are now into the uprise, particularly the alternative donor transplant in this chart, which is a CIBMTR data. So previously it was all a sibling donor transplant, and now we are more doing alternative donor transplant, which means a haploidentical donor transplant, which is a 50% match from the family, or a unrelated donor transplant, or a cord blood transplant. The commonest indication which I would like the nurses to understand why we do the transplant is, one thing is definitely leukemias, which is leukemias like ALL or AML. The second commonest indication is, second important indication is aplastic anemia, or in the other one, it is called bone marrow failure syndromes. The third indication is solid tumor like neuroblastoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, relapse setting, brain tumors. Other conditions which are not related to cancer, like immunodeficiencies, primary immunodeficiencies, metabolic syndromes, thalassemia and sickle cell disease, and autoimmune disease. So these are the broad indication of transplant, as we say in pediatric population. The commonest indication of transplant in the malignancy setting is leukemias, and in the non-malignant settings, which is a benign disorders, is thalassemia and sickle cell disease. Now, when we talk about a transplant, we know that the transplant is not a one-day job, it's a process. So how do we do this? How do we work out this process? So we start with a basic test called HLA typing. Once we do the HLA typing, and once we find the suitable donor, whether it is a 100% match or 50% match, the second most important part is the consent. right? So we explain the family and we take the consent. The third important part is admit the patient, and after doing the basic workup, we start the patient on conditioning chemotherapy. The fourth one is a collection. Fifth one is a processing of the donor cells. If required, we need to do a cryopreservation. Sometimes we do some reprocessing on the donor cells, and then we infuse, and then the patient gets better, and we discharge. Now, what is HLA? So HLA is as a simple blood test. We all have HLA in our body, and there are three major class of HLA: A, B, and C. And then there is DQ, DP, and DR. So when we see the HLA report, we see that these are the six components of HLA report: A, B, C, and DP, DQ, DR. Now, all the families will have either one child or siblings, right? So with each pregnancy, there is a chance of 25% match, whether your one child will be matched with your other child. In majority of the cases, you will have no match. But in 25% of the cases, when you have multiple children in the family, you may find the match. The chances of match being 100% with mother and father is quite low. So majority of the time, we have to look for the sibling match only. But what if we do not have a sibling match? So we have to find the donor in an unrelated donor registry like a Datri or DKMS, and we have to find the donor from there. And if we do not have the donor from unrelated donor registry also, then we have to see whether we can do a 50% match donor transplant or not. Now, when we do the transplant, there are three sources of stem cell. One is bone marrow, the second is peripheral blood, and the third is umbilical cord. So what is the difference between these three sources of bone marrow? Number one is bone marrow is the commonest and traditional way of doing the stem cell collection before a few years. I would say before 2000. But subsequently, when we are well versed with the peripheral blood stem cell collection, we are now having more and more peripheral blood stem cell source to be used in our transplant setting. And then the last is umbilical cord blood, which is preserved from the birth, and we can use as a source. So this as a cartoon for showing the three source of the stem cell. One is a blood, second is a bone marrow, and the third one is a cord. So this is the technique where how we collect the bone marrow. We make the patient lie down prone. This is a posterior superior spine of the both hip bones, and two operators needed, two doctors are needed, or technicians are needed. We need to dwell into this structure, and we need to aspirate a few ml of blood, and then we need to put them in a bag, which is ACD and anticoagulant bag with heparin. And then we keep on collecting this from the both sides simultaneously in order to achieve at least 3 to 5 million per kg of the stem cell. Now, how will you check whether it will be there? That will be checked at the end of the collection, but we have to collect based on the donor and patient weight. So let us say we have a sibling who is a 10-year-old. If his weight is 10 kg, we are allowed maximally to collect 200 ml, which is 20 ml per kg of the donor. And what is our aim? Our aim is to collect at least 10 to 15 ml per kg of the recipient weight. Means if the recipient weight is 20 kg, we want to aim to collect at least 300 ml. Okay. But we cannot exceed more than 20 ml per kg of the donor weight. So that is the important thing, how much we can collect from this procedure. It is done under general anesthesia. And this is the way we maintain the sterility, and we transfer the collected cells in the bag. The second is the easiest method, which is called peripheral blood stem cell, right? Just child is sitting on the couch and the blood is being collected in this machine, and then it gets separated in form of stem cell, and the remaining blood is going back to the child. The third one is a cord blood. You can see this is a cord blood unit, and once this cord blood is being taken out from the stored condition, we can use that as a stem cell source. Now, what is a transplant process? So first thing, as I mentioned, it is a conditioning chemotherapy. Second is a stem cell infusion. Third is a neutropenic phase. Fourth is an engraftment phase. And fifth is a post-engraftment phase. So what is a conditioning phase? So conditioning phase usually lasts for 7 to 10 days. The purpose of the conditioning phase is to kill the tumor cells if there is a leukemia patient or autologous, particularly autologous neuroblastoma patients and brain tumor patients and lymphoma patient. Provide a space in the bone marrow and to suppress the immune system, because some cases, like particularly immunodeficiency or aplastic anemia or a non-malignant cases, right? They are sometimes immune dysregulated. Some patients are overactive in immunity. Some patients are immune dysregulated. So we need to control their immune system, host immune system, in order for us to have the placement of our donor cells. Otherwise, they will reject the donor cells. So we need so the three aim is to kill the tumor cells, particularly in the solid tumor, to provide a space in the marrow so that the donor cells can establish in the hematopoietic system. And the third one is to suppress the immune system of the host so that it does not reject the donor. Now, what is a conditioning regimen consist of? It consists of chemotherapy, radiotherapy, and ATG or serotherapy or radiation. So, what are the chemotherapy drugs we commonly use? So, we can divide these drugs in a high intensity, which we call the myeloablative chemotherapy, average intensity, which we call the reduced intensity chemotherapy, and low intensity, which we call the minimal intensity or non-myeloablative chemotherapy. Which drugs comes under the high intensity means myeloablative chemotherapy? Classically, busulfan. Then cyclophosphamide, high dose cyclophosphamide. Then total body radiation, whole body radiation. Right? These are the more common chemo and radiotherapy agents which considered as a high intensity conditioning. Any 2 or 3 combination of alkylating agents like busulfan cyclophosphamide or cyclophosphamide busulfan, in addition to any other agents, or triosulfan, thiotepa, in addition to fludarabine. So all these conditions where you need a 2 or 3 alkylating agents, that also make the patient as a high intensity or myeloablative conditioning. The commonest conditioning used in neuroblastoma is like a busulfan melphalan. Both of these are considered as a myeloablative regimen. Reduced toxicity or reduced intensity regimens are something which does not include the full dose of busulfan, which does not include the full dose of melphalan, which does not include the whole body radiation, which does not include the high dose, which does not include the combination of 2 alkylating agent or 3 alkylating agent. So let us say simple cyclophosphamide with fludarabine, cyclophosphamide with ATG, fludarabine with triosulfan, fludarabine with ATG, fludarabine with cyclophosphamide. So all these conditions are considered as a reduced intensity regimen, which we particularly use in the cases where the risk of rejection is not very high. So when we are using the chemotherapy, we have to balance between high intensity chemotherapy and low intensity chemotherapy. If we use too high intensity chemotherapy, it will damage the tissue and it will lead to more complications like graft versus host disease or infections or VOD, all those complications. And if we use the low intensity chemotherapy, it can lead to rejections in the beginning, or it can lead to mixed chimerism even in the later period of time. So we have to balance between the high intensity and low intensity depend on the disease type. The second phase is a stem cell infusion phase. So it is usually completed between 20 to 30 minutes. It is a simple infusion if it is a non-cryopreserved product. If it is a cryopreserved product, sometimes we need to be very vigilant about the reaction, about the hypertension, hemolysis, seizures, pulmonary complications. All these things needs to be taken care, particularly if it is a cryopreserved product. In a fresh product, usually the complication rates are very less and it is as good as platelet transfusion. Majority of the time it does not react. Very rarely it can have a hypersensitive reaction. And same thing is for the cord blood. The third thing is your stem cell processing or infusion, right? So as I have mentioned, that it doesn't rarely cause reaction, but particularly if it is a cryopreserved, like a DMSO preserved product, sometimes it can lead to potentially life-threatening complication, particularly the kidney AKI, like corneal complication, seizures, or pulmonary complication. So we have to be very careful when we are transfusing the cryopreserved product. The third phase is a neutropenic phase, means you have given the conditioning, you have given the stem cells. Now there's a period when you are dealing with the low blood counts, particularly low hemoglobin, WBC, and platelets. So this period usually lasts for 2 to 4 weeks. And during this period, you practically do not have any immunity. So your child is sitting with no immunity and at risk of very high infection. So these are the time this where you need to make sure that your antimicrobial and antiseptic precautions are well in place, because you cannot afford the child to have a severe infection when they do not have the immunity. So this is a period when you need to be extremely careful about how you are dealing with the patients and how you are making your antiseptic policies. Now, what are the other common side effects during this period is mucositis, which you are all aware, diarrhea, vomiting, electrolyte disturbance, heart, lung, liver, kidney toxicities, bone marrow suppression, and some other complications like hemorrhagic cystitis, peripheral neuropathies. All these are acute complications. And the most important complication is infection, because they do not have their own immunity. Then comes the engraftment phase, means your counts, your stem cell has started working after 4 weeks or 3 weeks or 2 weeks. The WBC counts start coming up first, then hemoglobin and platelet and all these things. Hemoglobin is usually last to recover, but the WBC count is the most important thing to recover, particularly 0.5 or 500 ANC, what we call, for more than 3 days is considered as a period of engraftment. So once the patient engraft, by 3rd week or 4th week, we discharge the patient. And then we monitor for the post-transplant complication. This can last for months to years. So remember, the transplant is not only a period of 1 month or 2 months or 3 months. Sometimes you can deal with a post-transplant complication even after 2 years or 3 years or 5 years also. So we need to monitor these complications, and most common complication is graft versus host disease. So what is graft versus host disease? It is a major complication in transplant, account for 20% to 40% of the transplant. It is derived from the donor T cells, which recognize the host T cells as a mismatched cells. The risk factors are particularly older age, female to male means sex mismatch transplant, peripheral blood as a stem cell source, T cell depletion method reduce the risk of GVHD compared to non-T cell depletion method, right? And the chemotherapy intensity and all these things. So that is why we always prefer a young donor, male donor, to have a less GVHD, preferably a less intensity conditioning to have a less GVHD, and preferably in a haploidentical transplant, we want to reduce the T cell by doing T cell depletion or using high serotherapy, means ATG or CAMPAS, to reduce the risk of GVHD. Now, where's GVHD present? It presents in skin, GI, and liver. Skin in form of rashes, GI in form of diarrhea, vomiting, decreased appetite, melena, ileus, and the liver in form of hyperbilirubinemia or deranged LFTs. So this is just a simple grading of skin, means how many percentage of the body is involved with the rashes, whether it is less than 25%, between 25 to 50%, or more than that. The level of bilirubin, means this is all micromoles, so that is why it is showing as 25 to 40 or 4 to 40 to 75. Otherwise, it is like more than 2 to 3, 2 to 4, more than 4, like that in our units. And then diarrhea volume is 10 to 15 ml per kg or more than 20 ml per kg, more than 30 ml per kg, more than 40 ml per kg, like that. And on the basis of that, we can grade the GVHD. This is acute GVHD. And what about the chronic GVHD? So the chronic GVHD manifests in the form of tightening of skin, sclerosis, hypopigmentation, dry mouth, dry eyes. Gut means you can have, as I mentioned about the malabsorption, diarrhea, vomiting, weight loss. Oral cavity GVHD. Lungs, it can have a lung GVHD. Liver, again, jaundice, liver failure, bone marrow, and immune dysregulation. So how to limit the GVHD? As I mentioned, we need to use the immunosuppression like cyclosporin, methotrexate, MMF, tacrolimus. Those are the immunosuppression. We need to use the ATG or Campath to reduce the GVHD. Or we need to externally T cell deplete from the graft in order to reduce the GVHD. These are the three common ways where we can reduce the GVHD. Treatment is simple. The first line treatment is steroid. Majority of the patient respond to steroid, but some patients do not respond to steroid, and there we have to go for the alternative treatment like steroid sparing agent or a second line or a third line agent. So this is a broad schema, the cartoon of a chronic lung GVHD. You can see the hand, the back, the red skin, bullous skin, eyes, jaundice. You can see this is a picture of esophagus. You can see the web formation in the esophagus. You can see the CT scan of the patient where you can see the lung GVHD. You can see the oral GVHD, the whitening of leukoplakia, what we call whitening of the oral cavity. You can see the eye, the corneal scars and corneal GVHD. So the GVHD can involve any organ as far as we know. That is why it is important to address in your long-term clinic. So this is a child which we have transplanted as a kid baby on ventilator with such a bad lungs, and then they become fine once we transplanted. So transplants sometimes become difficult when you are dealing with infections. But if you are in a good supportive care system, if your nurses are well trained, if your junior doctors are well trained, we can really make a difference in the patient life, as you can see. And the most important message as far as the basics of transplant is concerned, that we need to know the process of transplant. We need to know the importance of conditioning, what it can go wrong during the conditioning. We need to know what can go wrong after the conditioning. We need to know the side effects of the drugs. We need to know the drug interactions. We need to know what blood tests which we need to do during the transplant, particularly the cyclosporin, tacrolimus, sirolimus levels, when to do, how to do. And also we need to monitor the patient hemodynamics very strictly like we are monitoring in ICU. So here I'll end and I'll hand over to my nurse manager, nurse in charge of the BMT. He is Anish. He is going to talk about the role of nurses in managing the patients. So while I'm loading his presentation, I'm happy to take any questions. If our nurses has any question from me, from my presentation, I'm happy to answer that. Please ask the questions.
If anyone wants to ask, they can unmute themselves and ask. We can take one or two questions while the presentation is being loaded.
So I hope that all the nurses has joined, has understood the basics of bone marrow transplant, right? From a doctor's perspective. But it is very important to know the basics of bone marrow transplant from the nursing perspective. Because as I can say that what we expect from the nurses are sometimes difficult for the nurses to understand and also difficult for the nurses to practice, right? So let me just load Anish presentation. He has made a very nice and brief presentation. It will be only 15 slides, but I can 100% tell you that the important message which he is going to give you, that is the thing which you are going to take it from here. right? Because we, as a doctors, needs to definitely make the nurses learn in a very simple way. And what is the practical difficulties which nurses face, that is most important.
Hello. Hi, good evening. Is it audible?
Yes, it is.
Yeah. Okay. As Dr. Chintan explained about the phases of bone marrow transplant process, I'll also explain nurses' role and responsibilities in each phase. So we'll be starting our presentation. So that is pre-transplant phase. The nurses have a basic role of baseline assessment and documentation on verification in pre-BMT workup, that is including CRE, that is CRE status we need to check. Then chimerism, which is chimerism sample in the allogeneic transplants we need to send before starting the chemotherapy and all this
I'm
process.
sorry to interrupt, Mr. Anish. Your slides are
Yeah.
not moving. Can you put them on presentation mode?
Not moving.
Yeah, it's not moving.
No.
Okay, 1 minute. Need
You
to put in a
continue. You
presentation.
continue talk. You continue talk. I'll try to move.
Yeah. So the nurses has to check the serology grouping and all the baseline blood investigations and
Yeah,
transplant
yes.
protocol. We have to get
You continue. Just try to stop share again.
1 minute.
Can you open it in the PowerPoint? That will help.
Is it moving? Just
Yeah. Can you please check right now? Is it moving?
No.
No.
You have to open. Can you see the option of open in PowerPoint?
Need to open in PowerPoint. 1 minute. Okay.
I hope that will work.
Okay. Okay. Is it okay right now?
Yeah, it is now.
Yeah. Okay. Okay, sorry for the interaction. And okay, here we moving to our baseline document verification and pre-BMT workup. In pre-BMT workup, we have to check the CRE status, chimerism or sampling, which is in the allogenic transplant, and serology and blood grouping must be there. And transplant protocol, which is stating the conditioning regimen, which as Sarah has already explained. what will be the medication and how much dose we will be according to the BSA. It will be calculated and it will be mentioned over in the countdown sheet. We can call it as a protocol. And environmental surveillance means in the BMT room preparation, basically, we have to check the air culture of the BMT and the cleanliness, and the room must be in a sterile mode before taking the patient. So we are even sending the air samples, which is fungal and bacterial. It should be within the limits. So the environmental surveillance will be done before the patient transferring to the BMT. Then the family and patient and family education is very, very important before taking the patient to inside BMT. That is called as pre-BMT counseling, do's and don'ts in the BMT. What and all the infection prevention practices from the parents. We need the cooperation and food restrictions, which is in the food restriction. We are mainly restricting the outside foods and raw foods. As in a view of infection prevention and infection control practices, just like biomedical waste management and their hand hygiene and personal hygiene, all these kinds of informations we have to give before the patient moving to the BMT. And CVAD preparation and assessment, that is central line insertion must be there, and we should be having a proper central line, which is commonly using Hickman line and the common central lines which we can use for the BMT. And in PICC line, after post BMT phase, we can use the PICC line also in the BMT unit. So the nurse's responsibility to check the patency after the insertion of central line. Is there any complication? We can do the troubleshooting before the patient moving to BMT. And of course, the patient, if it is especially in the adolescent age, there will be having a lot of anxiety and all this. So the psychological support for the parents as well as the patient is very important in the pre-BMT status. And in the conditioning phase, once we received the patient in the BMT, as an infection control practices, we used to trim the hair, and we need to ensure that the patient is taking after a chlorhexidine bath for the BMT entering. And we need to give the basic orientation for the patient regarding the BMT practices and BMT routines for to get a better cooperation from the patient side as well as the parent side. Then after taking the patient, we are administering the chemotherapy medicines as per the schedule. As sir mentioned, all the medicines will be there in the protocol, and we should get a return order for that before starting the medicines in the BMT unit. And the nurses must be able to handle the high alert medicine as per the medication administration policy. And previous slide. Okay. So we have to be extremely precautions. We have to take care about the medication administration while we are handling with the high alert drugs, which is cytotoxic drug. And especially the medicine cytotoxic drug must be administered through the central line only. And the medicine will be prepared from the biosafety cabinet to ensure the staff nurse safety as well as the medicine safety. Then we have to monitor the side effects of the medicines, acute and late side effects in the conditioning phase. After the medicine's administration, if the patient is developing any kind of complications or side effects, we need to identify them immediately, and we need to inform to the doctors as soon as possible. And we have to maintain a fluid intake output and balance in a proper manner, because the patient can have a dehydration and all such complications that may lead to severe complications also. And detailed dial history and bowel pattern we need to assess as a nurse. We have to take the track of a bowel pattern as well as the diet history. And if it is needed, we have to counsel with the dietitian for the dietary modifications. And supportive care, CVAD care maintenance, that is very, very important, as the patient is going to in a severely neutropenic status, so there should not be any source of infection from the central line associated. So the CVAD care and maintenance is very, very important. And the sitz bath, spirometer, and skincare and nutritional needs, all these things are important to maintain in the conditioning phase. Then the stem cell infusion phase. So the day which is giving the cells, the staff must be aware about the process and administering stem cell. In between that, we have to monitor the vital signs in every 15 minutes, and support to the child in case of any vomiting, abdominal cramps, and muscle contractions, which the nurse must be giving support. And monitoring reactions in the immediately after the transfusions, also in the middle of the transfusion, also the patient can develop a rigor, chills, and such kind of respiratory distress and desaturation, and any Pew score changes. The nurse must be able to monitor the signs and symptoms, and they need to be able to escalate on time and provide reassurance for the mother as well as the husband, because the parents also will be in an anxiety status what's going on with the child. So the nurse must be able to give the reassurance of this and prepare the patient and equipments before giving a stem cell. The nurse must be preparing the medications, and usually we used to give the double maintenance hydration for the better hydration status, and baseline vitals, and cross-check of stem cell bag, and all the basic life-saving supports must be there, with including the crash cart near to the patient. And O2 suction equipments, if it is required, the nurse must be able to use the oxygen supplies and suction equipments, and emergency drugs, and it must be a sterile field. And administer the stem cells, monitor the vitals in every 15 to 15 minutes, support the child in case of vomiting. Okay. That is post-transplant phase. Again, starting monitoring, engraftment monitoring. That is engraftment phase, as sir said, that it's around 7 to 15 days. It will take the cells to work up and the counts to come up. In between, there may be a support of growth stimulating factors. So the nurse must be administering as well as the nurse must be able to monitor the cells coming up in an engraftment phase, and to detect GVHD and VOD. Is there any skin changes, maculopapular rashes, redness, peeling, abdominal cramps, and right upper quadrant pain if the patient is complaining, nausea and blood in the stool, increase of hepatic enzymes, increase in abdominal girth, rapid weight gain, feeding intolerance. These are the few points the nurse must be monitoring in the phase of engraftment phase. And daily assessment, that is very important in the bone marrow transplant unit, that is including abdominal girth, weight, pain and intake output, skin changes, and nutritional status of the child. As well as the main important thing is to monitor the Pew score. The fluctuation in the Pew score must be highlighted. And for the mucositis also, the nurse must be checking the oral cavity for the mucositis changes. And lab monitoring, which is daily CBC, we used to do the CBC, and the nurse must be aware about the values and the upcoming treatment plan according to the CBC levels. And the bilirubin, SGOT, SGPT, as sir said, that in the GVHD or the liver GVHD, there will be a rising of all the enzymes. So the nurse must be aware about the baseline result, and the nurse must be able to highlight if any is there any changes in the mentioned blood test. Yeah. And the medication management, coming to the medication management, the nurse must be able to handle the immunosuppressant drugs, which is needed a dose adjustment as per the drug level, and early identification of toxicity, and proper sampling is very important in case of drug sampling. Otherwise, the patients will be getting an altered report, and based on that, the treatment will be getting disturbed. And next is pain and symptoms control. The patient may experience pain as so the especially in the pediatric population, we need to usage of proper appropriate assessment tools, which we need to use for the pain and assessments. So the nurse must be aware about the various tools which we are using for the pain, as well as the time planning of supportive drugs. So that is also very important that for the antiemetics and pain medication, it must be administered at the proper timing. Especially antiemetics drugs must be administered before the diet the patient is taking. So the supportive drugs timing also need to be fixed by the nurse as per the situations. And accurate documentation, which is very important from the nursing side. We need to keep a accurate record, and accuracy and appropriateness of documents should be maintained, and timely escalation of problems must be done. The nutritional support, monitor the intake, and if it is needed, we can manage with the oral. Otherwise, we need to escalate to the RT or IV, total parental nutrition or such needs. The nurse must be assessed, and it should be escalated as and when is required. And transfusions also having a major role in the engraftment phase. As per the CVC values, the consultant will be advising to transfuse multiple blood products, which is PRBC, platelets, and so on. So the nurse must be aware about the transfusions, and in case of any transfusions reactions or such kind of adverse reactions, so the nurse must be able to monitor and escalate at the transfusion time. And internal parental nutrition, usage of specific equipments like a feeding pump and TPN or such kind of nutrition support, the nurse must be oriented, and she must be handling this nutrition requirements in a proper way. The neutropenic diet education, it's having a major role in the BMT. So in neutropenic status, we used to say that we have to avoid the outside foods, and of course in the BMT we are not allowing the outside food or so. And diet education, the diet will be supplied in the pressure cookerized zone, that is in a method of autoclaving system we are using for to sterilize the food. We are considering after the autoclave process which is happening in the pressure cooker, the diet will be getting out of risk. So in hygiene and skincare, the nurse must be monitoring about the personal hygiene, and the chlorhexidine bath is mandatory for to maintain the skin infection parameters. And next is oral care. The patient must be using chlorhexidine content mouthwash, and each before and after taking of food, with the patient must be taking the oral hygiene. And skincare, we can use the emollient and all such kind of skincare supportive measurements to rule out to avoid the dry skin and such kind of skin issues. And linen hygiene. In the BMT, we are using the sterilized linen, which is getting by ETO. We are getting the sterilized linen, so that through the linen we can ensure there is no infection or the organism is getting transferred to the BMT unit. And of course, there is a role of a psychological support in the BMT. Especially for the child who is in the adolescent age, the nurse must be giving a proper communication, or must be a friendly atmosphere she should create for to avoid the psychological stress for the child. Being a long time bedridden status, or the patient may not be able to go outside the BMT unit, so the psychological support also is very important, and emotional support also will be given by the nurse. And to reduce the anxiety, the parents also will be going through a experience of their children's in the stress. And as we explained, there will be a lot of clinical issues for the patients, diarrhea, vomiting, and fever, and lot of such kind of complications. So the mother and the father must be explained the process well, and this is a part of BMT treatment, and the baby will be out of these problems once the engraftment is started. So the nurse must be able to give the psychological support, and if it is needed, we need to escalate to the professional counselors or to ensure the proper psychological support is provided. And documentations and quality of the process will be maintained, and maintain records of BMT process, which is having especially in the dates and all this BMT entering date and stem cell transfusion date, and such kind of data must be collected, and it must be recorded as well. And monitor the quality indicators as per the hospital policy, like central line infections and such kind of indicators the nurse must be following. And then maybe JCI compliance structures are appropriateness as per the criteria. It's a nurse's responsibility to maintain the data compliance as per the hospital policy. And the nurse must be able to manage the emergency situations like febrile neutropenia, early identification of febrile neutropenia, and antibiotic administration after culture and sensitivity sampling. Anaphylaxis reactions, drug and transfusions can plays a major anaphylactic reaction. So the nurse must be able to identify the allergic reactions and symptoms and initial management as per the severity. On the next is bleeding management. If the patient is developing an epistaxis and the PR bleeding, identification of GI bleeds, management of hemorrhagic cystitis, all this can be happened at any moment in the BMT, and the nurse must be able to handle all this emergency situation. And timely escalation of emergency situation is also very important than moving to a complicated situation. And discharge education, infection precautions regarding the personal hygiene, oral and perineal hygiene, neutropenic care, this and all coming under infection precautions. So before giving the discharge itself, the parent must be able to take care about the child in the home care setup itself in a infection preventive manner. And the medication adherence, and at the time of discharge, the patient may be in the support of hypertensive and immunosuppressant and nutrition supplements. Especially in the hypertensive, the mother or the father or the caretaker must be able to identify the BP changes, and if it is needed, the medication modification also. So there must be a proper training before giving discharge itself. And in the CVAD, the central venous access, the majority of the patients are getting discharged with the central venous access device. So the parents must be aware about the care and maintenance of devices. And mainly we are advising for the CVAD 7th weekly dressing and flushing. The patient must be, parent must be aware about that. And the child has to taken care about the central lines. And follow-up care, fever management, scheduled lab test, and importance of performing that test on the times, and then diet modifications, emergency home care management. These topics must be discussed with the parents before the patient is getting discharged. So here we can understand that nurses play a vital role in ensuring safety, recovery, and holistic care in the pediatric BMT units. Okay, thank you. If there are any questions you can ask regarding the nursing care of a BMT unit.
Thank you very much. It was an excellent presentation with Dr. Chintan covering the history and basics of BMT, and very practical to the point presentation on nursing aspects by Mr. Anish. So we have a couple of questions in the chat box. So first question is, how frequently need to send air culture?
3 times we are cleaning for the performing a deep cleaning of the unit, and 1 time we are sending the culture. If the bacterial and fungal growth is under the control, then we can take the patient. Only 1 time culture is mandatory, but 3 times deep cleaning with the chemicals which we are using. Virkon solution is the chemical which we are using to do the cleaning. So 3 times deep cleaning and sending culture 1 time.
So just to be clear, this is every time you are taking the patient in the new room, you are doing this.
Yes, before taking a new patient, the room must be done this process 3 times cleaning and air culture. This is mandatory to take before the next patient.
Okay, so the next question is, could you please clarify the diet protocol? Is there a chart specifying permitted and restricted items? Kindly let us know. And what beverages they can take?
In the dietary modifications, mainly the aspect of infection control, it's coming, and the next is as per the calorie requirement that is dietitian is supporting, and dietitian will be providing a diet chart how the as per the calories. So the beverages which is coming in a tetra pack we can use, and avoid the milk and milk products. These are the major measures which we are taking, and there is no raw fruits or raw foods like cucumber or such kind of things. So anything can given in a boiled this one manner we can give.
Okay, so next question is, are you following any protocol for central line removal? I'm guessing this is in the case of clepsy.
Yeah, if the patient have significant culture positive records which we need to remove, it must be removed. Otherwise, after the engraftment phase, to keep more than around 1 year is not much suggestive. If it is fungal infection or any such kind of dangerous infection situation, the line has to be out within no time.
So, next question is fogging of room required?
No, there is no fogging protocols in the practice right now. The deep cleaning with the Virkon solution and the air sampling, that is a protocol. There is no fogging currently practicing.
Okay. The next is, during mucositis, which type of diet are you suggesting?
It's of course there should not be any spicy foods which we are giving to the child, and for to support the mucositis, we are using such kind of easy treat and such kind of mouthwash and sweet containing diet the child can take as per the severity of the mucositis. If it is in the third and fourth stage of mucositis, we may need to give the nutrition support through the RT feed, and the patient will be in a nilper mouth till the status is improving.
So this is in the interest of time, I'll take this last question. What
Yeah.
nurse to patient ratio are you following?
The ideal thing is 1:1 ratio suggested for the BMT. In our hospital, we are doing 1:2 up to 1:2.
Okay. And the last is, what type of mouthwashes are you giving for mucositis patient?
So basically, we are starting with the chlorhexidine mouthwash. As the mucositis is getting developed, the chlorhexidine may irritate their mucous membrane. So we can use the easy treat mouthwash as well as the soda bicarb mouthwash also we used to give for to control the mouth ulcers. And we are giving the glutamine sachets for the easy recovery of mouth ulcers.
Okay. So I would like to thank Dr. Chintan and Mr. Anish, both of you, for the very nice and informative session. And we look forward to many such webinars. I'll hand over to Himanshi to conclude the session.
Thank you.
Thank you.
Thank you so much for joining the session. I'll be sharing the feedback link in the chat box. Participants can fill the feedback form. Thank you so much.
Thank you.